Dile, Gre. ¿Ah? Nah, make it tahu kan itu. Ada garden di sini ada. Kata tahu. Ada tekstil ke kotor ni garden. Ada ni. Tekstil kan. Ada rahu aku pikir kan make it. YouTube description ni. ECG. Oh. Aigala mit garden di sini place ni. Replace it. Oh ya, आपका लदीन हो. University site lagi? University.
Hello, is it Mr. Henry Turner? Hello, nice to meet you. My name's Marie, one of the student doctors. Is it okay if I have a chat to you about why you've come in today?
Dan යනවා අය. බලන්න යටම තියෙනවා යටම. මේම සාමාන්‍ය අර විනාඩියක ඩිලේ එකක් තියෙනවා. දාලා දෙන්න ලයිව් කාස්ට් කරනවා. මේ යුනිවර්සිටි සයිට් එකේ පල්ලෙහා තියෙනවා මේ වීඩියෝ ස්නැප් එකක් යනවා මේ අර නිවුස් වලට එම පල්ලෙහා ගෙදර යන්නේ. ගෙදර තියෙනවා. හරි. भैया नेटवर्क කියලා ස්ලෝ है මානක ස්ලෝ है डाउनलोड කරලා තියෙනවා ගොඩක් වෙලාවට මේ සයිට් එක ඕපන් වෙන්නේ නැහැ පරීක්ෂා කරලා තියෙනවා නෙට්වර්ක් එකේ යූස් කරනවා
The other day, a young junior doctor said, communication in patient-centered healthcare is not just extracting information from the patient, but it is an art to be mastered. Ladies and gentlemen, to start the proceedings today, I would like to welcome Professor Chandrika Jayasinghe, Professor in Medicine and Coordinator of the Postgraduate School of Medical Sciences, to deliver the welcome address.
Good morning, ladies and gentlemen. Thank you, Rosita. I am delighted to see hall full of doctors and medical students, and when I entered the hall, I saw a consultant physician from little away place coming here. So there are, I think, it's a diverse group of people, doctors, medical students, among the doctors also, very senior, intermediate, and new doctors. So we welcome all of you to this very important session of communication skills with patients, because I think it is one of the most important skills that you need to develop if you want to have proper relationship with your patient. So we have been talking about knowledge and skills. We know that knowledge and skills are very important to arrive at a diagnosis and to proceed with your patient. But if you have knowledge and skills, but if you do not have communication skills, obviously you would not deliver the required things to your patient. So here you are to have a 2-hour seminar on how to bridge that gap that we have on communication with your patients. So I welcome all of you who are here today for this program. And I would like to make this a welcome address and also kind of a vote of thanks, because there are so many people behind this program. This is not just a 2-hour seminar. First of all, I would like to thank Dr. Rasnayaka Mudiyanse, Head Department of Pediatrics and Senior Lecturer in Pediatrics, who pioneered this program. So this was a cascade of programs, workshops, seminars, not only in Peradeniya, in Colombo and various other places. So I thank Dr. Mudiyanse for originating this idea and doing it, making it a success. And then I thank Professor Jonathan Silverman and Professor Mercy Rosenberg, coming all the way from US and UK and US to make this a reality. And we have our own Professor Tilda Silva from our own faculty, who has been here for more than 40 years from the Department of Department of Sociology. Welcome all three resource personnel who are here today to make this event a success. But there is a person who was behind all this. Now we are conducting this yesterday workshop and today's seminar through this newly established Postgraduate School of Medical Sciences, University of Peradeniya, which I am the coordinator. But there was a live wire behind this yesterday's and today's program, that is Dr. Roshika Waduge, Head Department of Pathology. So I thank her for doing all this hard work, and the office people in the Postgraduate School of Medical Sciences. So without taking much of your time, I invite now Dr. Rasnayaka Mudiyanse to introduce the resource people to you all.
Good morning, everybody. But just to introduce the program and introduce the resource person. In fact, this how it happened was I was entrusted to introduce or rather enhance teaching family medicine in this faculty. Now this trouble is sort of on my head for last 2 or 3 years. All the faculty meetings, people are asking what about family medicine initially, and then later on when I start talking about family medicine, you know only about family medicine, and sort of it was going on and on. So in that process, I was searching this, googling these topics: good doctor, patient-centeredness, empathy. In the process, I came across this big book on doctor-patient communication, patient-centeredness. Authors were Professor Jonathan Silverman from UK, Cambridge, and Coates from Calgary, Canada, and another. He's one of the main author in that book. So I wrote to him explaining that I want to bring this in, and whether you can help me come to Sri Lanka. I think he was surprised with that request. But then we had exchanged a couple of emails. Finally, he agreed. Professor Jonathan Silverman is the president of the European Association for Communication in Health. European Association for Communication Health is not just in Europe. It's in America, Canada, Australia, and all over. So it's a much bigger world organization on communication on health. So with us, we have Professor Jonathan Silverman, who is the president of that association. So Jonathan Silverman has written 2 important books, and there are about 6 books on his name, but then 2 important books: how to communicate with patient and how to teach communicate, how to train the trainers on teaching communication skills. So there were 2 important books respected by people who are interested in communication all over the world. And he has about 45 publications, we counted yesterday, and several chapters in several books. And he's taking the leadership in examining undergraduates on communication skills. So developing those orchestrations, how to do it, how to standardize it, and all that. He is taking a leadership. So we are lucky to have a person like Professor Jonathan Silverman with us today. But I have one problem with him. No time. I asked him, can you please verify? He said, no, I have not done it in my life. I am not doing it even in UK. Okay. And then along with him, we have Professor Marcy Rosenberg, and she is the chairperson of the teaching committee of European Association of Communication in Health. She's a professor in family medicine in Iowa, Kentucky, University of Kentucky, Iowa, University of Iowa in USA. So she's a scholar and she's a researcher, and under her name, I think that about 40 pages, it's impossible for me to read it. There are about closing upon about 60 publications in international peer-reviewed journals and several books, and she is supervising so many PhDs. So what I suggest for medical students is just to put these names, 2 names in the Google, and then sort of read who they are. So I think that's the best thing to do. And along with that, you will get a lot of articles to read, and that will be a sort of very interesting thing to do. And one of the very important articles is marrying content and process skill. So just you will get it free of charge. That's available. So our 2 key resource persons are those 2. But in addition to that, we have our 2 local very important resource persons. First, I will introduce Arosha Pereira. I think you all know Arosha. Arosha is the student counselor, senior student counselor. Now she's a career guidance job. And we were just having chat. She was telling that she's going to many other universities to see whether the career guidance things are happening. And she's here to tell us some stories about patients. And today she will present those stories about patients. In fact, more interestingly, she was telling us about the stories behind the gym. I think we should organize another session for that. That will be interesting. They know what it is. And Professor Tudor Silva, I think you all know, he's senior professor in sociology, and just sort of wait and you can listen to him and you will realize what sort of a speaker he is. And in fact, he's taking a lot of international level leadership in that field. And I mean, so many books and so many publications. I'm not going to sort of go into that. So we'll start off. May I invite Arosha to do her presentation. In fact, Arosha was insisting me to tell the audience here, this is only acting, not actually her personal experiences, so that don't get annoyed with her.
Good morning. Ladies and gentlemen, I'm privileged and honored to talk to you, especially the doctors. But I asked Dr. Williams to listen. I don't think he could understand my question because finally I understood that he was a doctor. So, anyway, he explained me, okay, this group, most of the teachers and educationists, they really, person's perception about the doctor behaviors, they really look at the patient's perception about the doctor's behavior. So then I thought, yes, Dr. Yes. I remember, yes, not less than 7 years, my brother called me. Akka, Amma was not well. You have to admit her to hospital. Then we are in the hospital. My mother being on the bed, unconscious. Couple of days, nothing. I'm really worried. I gave my brother without channeling straight away to the hospital. But 2 days, blood test, scanning, lot of tests and so many things. Nothing. I'm really worried about that. I really wanted to talk to someone. When I was walking to the ward, was the corridor, a doctor passed me. He recognized me and stopped. Are you Mrs. Bandar daughter? Good morning. Can I talk to you? Again, of course. Said yes. Said come and give it to me. Doctor's room. So many doctors, very busy with the patients. And he's taken to the chair on the list. 1 or 2 doctors stand up and certainly sit. Then I realized, yes, maybe the senior one, maybe the consultant. So he said, okay, go ahead with your work. And there is a chair on the table, and he then loaded with the files, and he came up and asked me to sit. Yes, he asked me to sit. Doctor standing. How can I? He said, remaining standing. Okay, then he started talking. Harsha, I'm a teacher in this board. But you know, are you working? But you know about that your mother's illness. And he tells me, Finally, he told me, my mother is having a very severe brain hemorrhage. In her age and the physical condition, can't do anything. Impossible to stop the time. I been on the wall and he sit and call the nurse. He was holding my hand for a while. I saw tears in his eyes. I really wanted to hug him. That is the story. Last month, I heard Dr. Ramji talking to the young doctors. You have to have a parallel level seating management, 45-degree angle, eye to eye contact. Doctor, we don't have anything. We don't have anything. I really understand that Dr. Murian gave that doctor, why don't you call us earlier? And couple of days that one hospital director talking to Dr. Murian said, so we need more chairs, adequate chairs, table space to develop the communication. I was there. I said, yes, okay, that's a good idea. That's cheating. Better to tell the stories. Any young patient, no? It was in my pregnancy. Just imagine, Anusha is going like this. I was got fever. It was Sunday. My VOG is not available. My husband told me, can you do OPD? I said, yes, okay. You know that sometimes our wallets financial difficulties, so we look it. Amen. There is a man wearing the white clothes. He's not his head. I said, what? I think, doctor, table, and chair. Why? Doctor. I don't know if it or not, but so I give my all the reports, statistics, and everything. Channel show them to the VOG. Tell me your illness, please. Then my husband would step back. I didn't know, he was a backbone list of wise man. Anyway, I explained my illness as a patient. Doctor wrote me a medicine. Not bad. We did our job. Anybody else? Just find another next patient here. I say that. My husband holding my hand and tears in my eye. He said, now I realize he is a wise man. Suddenly, yes, oh my doctor, I'm so happy. He always ran to me. But the person that is so busy with some work, he looked at me, say, please go to the OPD doctor. Me. See, okay. You understand, recognize me so that I try to explain to you that I'm Charlotte. And look at me. Aren't you understand, Singh, that I'm not seeing the patient in the OPD? Yes, Professor. Very good. I can that. Excellent. I came back to my shelter. But my husband again wanted to call him that because I need him another 2 things. And even yes, I need my room as well. So thanking everybody, we went home. But man, yes, I pray. I wish my husband need more money. Just only one. Give me another 2 minutes. I'll have one story. This is after the delivery. My first baby, 3 weeks, I have a big problem. I'm really worried because she might get embarrassment. Then I went to the doctor and I start talking. I'm sure I didn't have milk that you know my mom is melting. What? Embarrassment? I never thought. Did you read it? Who told you? Don't tell anybody that they did that. Yeah. Man, you think that you don't have any milk? You find out my test. Actually, I really wanted to teach him the answer. The test not equals the milk. I mean, but he wanted. In fact, my mother-in-law interviewed her. Yes, doctor. That's enough milk. But my poor mother helped me. But still, I believe big best mothers have some feeding problems. And the medicine story as well. But I don't want to get any argument with him. He's a very nice person, and I can do with him. There is a serious doctor's consultant here. I'm sure patients start to be silly stories here. These are the correct stories when they are not. Please listen. Thank you.
Good morning to everybody. Can you hear me, first of all, at the back? Nod if you can hear me. There's hardly anybody nodding, which probably means you can't hear me. Can you hear? Put your hands up if you can hear at the back. I don't know. Good, thank you. Welcome to everybody, and thank you very much indeed for inviting both myself and Marcy Rosenbaum to speak to you today. It's a delight to be in Sri Lanka, and we hope very much that this is a continuing process, that we're going to start looking at how we can improve doctor-patient communication and the teaching of doctor-patient communication here and elsewhere in Sri Lanka. So we're very, very pleased to be here. Both of us represent EACH, the European Association for Communication in Healthcare. I'm the president of the organisation, and Marcy is the chair of the teaching committee. Now, I'll just show you that there is a website, each.edu, very easy to remember, and for teachers in particular, and for students as well. It's got lots and lots of resources available free to everybody about what to teach and what to learn, how to teach, how to assess, and training the trainers programs. And all that material is available free to everybody. So jot the name down, go to it if you're interested, and if you're really interested, particularly if you're a teacher, become a member. We have members from all over the world, and we only need 5 members maybe in order for you to sit on the steering committee. I'm sure it'll end up being good. So we need your support. Now, what are we going to talk about today? patient-centered communication, lessons for clinical practice, and for the teaching of patient-centered communication. I'm going to talk about the lessons for clinical practice, and Lars is going to very much concentrate on teaching. Okay, we've heard a lot already about, well, Marusha, about the patient's perspective of being on the other end of the medical interview. And actually all of you in the room have been patients as well and have had your own experiences of this. But this fundamental model explains a little bit about the problem in doctors talking to patients. This model was developed by Canadians, McWhinney and Stewart, in the 70s and 80s. It's a fundamental principle of the sociological aspect of the medical interview. And let me just explain it in a little bit of detail so you get a feel for what this is all about. So, all of you, the medical students and all the doctors, are trained very strongly to find out the sequence of events, the symptoms, eventually the signs, physical signs, to make a diagnosis after you've done investigations and considered the pathology. That is the fundamental job of being a doctor and has to be done. This side tended in the past to be very much the province of counsellors or people not as doctors. When I trained in Oxford in the 1970s, we were told that this is what you need to find out. Many patients come with different ideas and concerns. The important thing to do is to put that in the rubbish bin, because that is the thing that gets in the way of you making a diagnosis. However, if a counsellor finds out about the patient's ideas, what they're worried about, what they're concerned about, how it's affecting their life, and their expectations of what the doctor can do for them, that counsellor is finding out each individual's own perspective, which is unique. And just for a moment, all of you think of somebody who's presented, 5 people say you presented with the same condition. It could be angina, it could be malaria, it could be TB. Each of those persons comes with a totally different set of ideas and concerns. Firstly, they might be worried, say angina, that they're going to lose their livelihood, their work, because they can't work with that condition. Or there might be somebody who's quite comfortable with that diagnosis. Their parents have it and lived to a relatively old age despite having angina and taking medication. Or they might have a detailed understanding of cardiac anatomy, or know nothing about the human body, or have traditional health beliefs about what chest pain means. They may have expectations of the doctor to do something which will cure this problem, or simply to have something which enable them to work or pray or go to see their relatives. So everybody comes with a unique experience. And actually, that's the beauty of medicine. The beauty of medicine is seeing people and helping them with their concerns and their thoughts about it, and that everybody is different. The reason this is so important is it turns out that when you go to the explanation component of the interview and try to tell somebody what's going on and what they need to do, the evidence is very clear. Unless you understand where they're coming from, the chances are they won't buy into what you're telling them. Say that man with chest pain, it's very clear to you it's musculoskeletal. It's a full muscle effect between the ribs, an intercostal problem. And you just tell them that. But they're worried that their father died at the same age of a sudden heart attack. They will go and see another doctor probably. If you find out that that's what they're worried about, and explain why you know it's not that, and why you're certain it's musculoskeletal chest pain, then they'll understand. Because you know what they were worried about, and you can tell them why it is. And a real effective doctor isn't doing this in a sequential way. Let's find out all the symptoms, and let's ask a few things about patients' ideas. They're weaving backwards and forwards between these two, listening to what the patient's saying, finding out about the biomedical and the patient's perspective. That weaving backwards and forwards is all to do with how you pick up non-verbally and verbally that the patient is worried or has ideas or has concerns. We'll come back to that. Okay, so patient-centered communication. That sounds a very nice buzzword. Sounds something which sounds a good idea. That would just be pleasant to people. Actually, it's much, much more than that. What I want to impress upon you is that patient-centered medicine is evidence-based clinical communication. In other words, for 20 years we've been collecting evidence that if you do the basic skills of patient-centered communication as a doctor, you will actually be a far better clinician and your competence will increase. It's not simply a matter of being pleasant. This is actually about clinical outcomes for patients and whether or not they take medication, whether or not they are satisfied with you, but most importantly, health outcomes. So it's about clinical competence. And the way many of us have practiced, including myself, in 20, 30 years ago, does not lead to effective medical practice. I'm going to tell you a story first, which I think is highly relevant to this. So if you imagine, this is true, 2 years ago, I was admitted to my own hospital with chest pain. And I spent 2 days, first of all in accident emergency and then on the ward, before they discharged me, telling me that I had atypical chest pain. In other words, there was nothing wrong with me, I was fine. You could see in their eyes that what they really felt was that I was, just making it all up. But they said it was atypical chest pain, which is a good diagnosis. However, the person in the bed next to me had severe pains, a past history of infarcts, was much older than me and was obviously quite unwell. And he was admitted to the bed next to me, so I saw him being dealt with by doctors over a 2-day period, in which time he was interviewed, his history was taken by 6 doctors. 1 senior medical student, 4 junior or middle grade doctors, and 1 consultant. And the 4 middle grade doctors, every one of them missed the diagnosis in time. Nowhere near it. The medical student got it within 1 minute, and the senior consultant got it within 1 minute. And my question to you is, what were those 4 junior doctors doing that was interfering with their effectiveness? And let me tell you, doctors at Addenbrooke's Hospital in Cambridge are pretty smart, they're bright, they're intelligent, they're perfectionists, they are the top of the bunch. So, something that was going on there stopped them being clinically effective. Now hold on to that thought, because I'm going to return to that at the end of my lecture and come back to it. But it's integral to what I'm going to say. So if you're going to be a good doctor, and be competent, there are several things to do. One is knowledge. I just ask the medical students, do you think they spend a lot of time giving you knowledge? The answer is yes. That's what the medical curriculum is all about. You need the knowledge, absolutely. You also need the ability to physically examine and to do procedural skills. Do people take care of that? Yes. Do they watch you clinically examine to make sure you can do it? Yes, very good. The next one is problem solving, the ability to clinically reason. Clearly, it's not just knowledge, it's actually knowledge in application to work out while with a patient what's going on. And the 4th is communication. And unless you can communicate, all the rest of your efforts come to nothing. You need to take a history in such a way that you can retain high quality information. You need to give information to a patient and plan with them in such a way that they buy into what you're saying and that they adhere to a treatment plan, that they understand what's happening and that they feel comfortable with you as a doctor. Now, I would just like to ask you if you can imagine a doctor. It's all right, the medical students are at the back, so the doctors here, if they don't turn around, will not know what you're saying. Can you imagine a doctor with high knowledge and the ability to physically examine who's got ineffective communication with their patients? If I ask students and parents about that, they've all seen hundreds. Doctors who aren't very good at communication, but are very good technically. But there's another problem. You can have doctors who are very good at communication and don't know anything. Okay? I had a partner in my practice, as a doctor, the patient said, I do like to go and see Dr. Ellis, but I wouldn't go and see him if I was poorly, if I was really unwell. Now that is not an effective doctor. That's just someone they like seeing. That's not what communication is. Communication is not just about being nice. It helps, but actually it's much more important than that. And the research says that with effective communication, you end up with more accurate, efficient, time is always a factor here, efficient and supported interviews, that you can enhance both patient and professional satisfaction and improve health outcomes for patients. Now that is another lecture. I'm not going to do that one today, but there are evidence over the last 30 years that suggests that through effective communication, you will end up with, for instance, reduced HbA1c and blood sugar levels in patients irrespective of what their operation is. So there's a central importance here of effective clinical communication to high quality healthcare. Okay, now here's the next question you might be thinking in your mind at this point. And I'm very happy for you to engage with us in discussion about this at the end in particular. And that is what I'm talking about something that's only applicable to Western practice? Is it a paradigm that's unsuitable for Sri because you have stronger hierarchical relationships, probably with your teachers as well as with your patients? Because there's a degree of conflict avoidance from patients and hinting at things through non-verbal rather than direct verbal challenge? Because clinical decision making is very much more community or family rather than individual responsibility, because alternative medicine is everywhere. Does that mean that patient-centered medicine wouldn't work here, that you have to be paternalistic in order for this system to work? And there are some reasons for saying that that's true. For instance, if your time aliquot for seeing patients is very, very reduced, it's hard to do anything. I don't think that's a problem between paternalism and patient-centeredness. That's a problem of the system, if you like. And I would know it's difficult to be an effective doctor if you've only got 2 minutes. However, the evidence is if you've got 10 minutes, being patient-centered is actually quicker, and I'll come to that. So the question is this a Western paradigm? And let me strongly say where I'm coming from on this, and where the research in Asia is leading, which is that's not true. And in fact, although there are differences in stereotypical or overall global perspectives between how patients behave in the US, which is different from the UK, which is different from Asia, actually, within any one community, there's enormous variation. And so the individual, whatever community you're from, will have very different perspectives on their own healthcare. And the question is how to be flexible to them. How do I find out how to behave with this person and what they want out of this consultation? That's different from taking a cultural norm and saying all old people do not wish to be involved in their own healthcare and make decisions. My mother's 92, if you said that to her, she'd probably hit you. She wants to be very involved. My father's 93, he doesn't want to be involved. Okay, so this is exactly where patient medicine comes in. This is that, what patient medicine says is you find out from each individual patient what their needs, their ideas, their concerns are, how they want to be treated, and you work with them. And so that's actually applies very well to this community. And in fact, the original research, which came from the 70s in the USA on this confinement, was about doctors in the USA treating patients who were from China. The Chinese community is very large, and how they got it wrong all the time because they didn't understand the health beliefs and concerns of that community. It was then extrapolated to everybody. You can do this with every individual. So I think it does apply, but we can talk about that later. I'm now going to show you 3 examples on video. Then I'm going to talk about, if you apply these examples, what the prize is. And then I'm going to just briefly go through a model of patient-centered communication, which I know that Moody is very keen to use here and to think through as a method of interviewing. So these are the sorts of areas in any consultation that you could be thinking about: initiating, gathering, relationship building, structuring, posing the interview. Let's just look at the very beginning of an interview. I'm going to ask you, all of you, to watch 2 videos, just for a minute or 2 of each, back to back. These are 2 junior doctors in the UK, so this is a Western example. Each interviewing the same simulated patient. In fact, we were setting up an OSCE station, we wanted to see if it worked. We got 2 junior doctors from the wards to just do it as if they were doing it for real. And asked so we could see how it worked and whether it was a suitable case. So this is a patient coming with a chest infection. And they were asked just to interview, and that's what they've done. So, my question to you is, when you watch it, is, can you see different patterns between the 2? And if you can, what outcomes do you predict these different patterns will have on their effectiveness as doctors? Not on whether they're nice, on their effectiveness as doctors. So I'm going to show you them back to back. Then I'm going to get you to talk to your neighbour for 2 minutes, saying what you've seen. And I'm going to ask you to say which one is most effective and why. Okay? Ready? So I'm going to involve you in a minute. That's what the roving microphone is for. And I'll be starting at the back and working forward.
Hello, is it Mr. Henry Turner? Hello, nice to meet you. My name's Rich, I'm one of the student doctors. Is it okay if I have a chat to you about why you've come in today?
Oh, yes, please.
Can I take a seat?
Yeah.
I can see you're quite short of breath there. Are you would you like to put your oxygen back on?
Oh, I've had a bout and I'm not too bad now.
Okay. Can I ask you what's brought you into hospital today?
It was the shortness of breath. The breathing, it's got worse.
Okay. And you said it's got worse. When did it start?
Oh, about 24 hours ago.
Okay. And before, what was your breathing like?
Oh, quite normal, really.
Okay.
Yes.
And have you been unwell at all?
I've had a bit of a cough, which developed a couple of days ago.
Okay, so you've had a cough for the last few days.
Yeah.
Are you bringing anything up with the cough? Any phlegm?
I am, yes.
You are?
Yes.
Okay.
Not all the time now, only occasionally.
And what colour is the phlegm?
Well, it started off as white.
Okay.
And over the last 24 hours, that's become a sort of brownish colour.
Okay. And have you noticed any specks of blood at all?
No.
Maybe strips?
No.
No, nothing like that. Okay. And the shortness of breath you said started 24 hours ago?
Yes, yes.
And did it come on suddenly or gradually?
Okay, now let's just watch the second one. We'll do the same at a time.
Taking time, please.
Hello, this is Henry Turner.
Yes.
Hello, my name's Nicola. I'm one of the stage 1 medical students.
Right.
Nice to meet you. Would it be okay if I find out a little bit about what's been going on to bring you to hospital today and those the doctors? Excellent, thank you very much. Hello then, tell me what's been happening.
Oh, it's my breathing, doctor. It's got worse.
Okay, tell me a bit more about that.
Oh, about 12 or 24 hours ago, I suddenly started getting a shortness of breath. That's got worse and worse to the point that I'm now short of breath all the time. Earlier, it was just when I was trying to walk across the room or doing something. And now it's got worse.
Okay, right. So you mentioned that the shortness of breath, which came on about 24 hours ago, started when you were exerting yourself, but now has become there all the time.
Yes.
Okay. Have you noticed anything else at all apart from the shortness?
Well, it all started with a cough, really. That was the last couple of days. I had a dry cough.
Right. So that's the shortness of breath and the cough. Is there anything else that you've noticed at all?
Yes, I can pain. Yeah. There's a pain there, that's all right now.
Right.
With a cough.
Right. Okay. Would you like me to get someone to get you some pain relief for that?
No, it doesn't last very long, and it's so I can take it.
Okay.
Okay, now, just for 2 minutes, turn to your neighbour and talk about this question. And at the end of it, we'll find out which one people think was more effective and why. And I can tell you that in different audiences around the world, it's not clear which one is always the best to people. And I will help you with that. Let's see. Go talking now. There's going to be lots of noise. Okay, so let me start wandering around. This is like a TV chat show more than a lecture. Okay, so first of all, what I want you to do is to vote on this. Now, it's embarrassing to vote on these sorts of things because you don't know what everybody else is going to say. So I want everybody in the audience, first of all, to close their eyes now. I don't want to see any eyes. Close. Okay. And I want you to vote so that you've no idea what people are saying on whether you think the first is the most effective. So put your hand up if you think the first is the most effective. Now put your hands down. Now put your hands up if you think the second is the most effective. Okay, very good, thank you. So of course now you don't, unless you cheated, you've no idea what the voting pattern was. I can tell you the majority by far thought the second was, but some people felt the first was. When I showed this to an audience of British postgraduate doctors, a third of them think the first was most effective. But let's just explore why. Why would they say the first is the most effective? Can anyone shout out something? You've got microphones around. Why would people, not necessarily having voted, but why do some people think the first is most effective? What does it do? Big brain. You're all doing what I call reverse non-verbal communication, which is looking at your feet. Okay? Look at me. Let me ask you, why do some people here, why do some people think the first is the most effective? What does it do? What does it tell? Any ideas? Yeah, thank you. You opened your mouth. That's a very, very important yes. Yeah, no problem.
Because directed to answers. We had a time in this back of mind to some sort of diagnosis. At a certain time, we got the information from the patient. But I think it's a senior person who was working the first time, that's because he has experience and the knowledge. So we can quickly extract the necessary information.
Very good. Okay, so all of you, what you're saying is all very right people. You can engage with me on this. So yes, so often experienced clinicians will think the first one is better because it gets to the point. It gets there fast. Because they understand the patterns, they can do that. And actually, as we'll come to it, the research says that's not true. That's what everyone thinks. But unless you give a minute at least at the beginning for the patient to tell their story, there's a problem, and that is you jump to false assumptions. And you think you can get there very fast, but you might miss some important things. So, you're right, that's exactly the reason why people would say that. Okay, what you see in the second one, which is actually more, is, if you like, effective in getting this patient to tell their story. Can I just get, you don't have to say very much, just one skill you saw. And get some ideas? And have you got any ideas what you're watching? One skill? I should pick on people mercilessly if you don't contribute. I'm really horrible. Okay, you're giving me eye contact very badly. You're using good communication skills. Okay. What one thing did you see her do?
So because we just asked you open-ended questions, consider that the scenario, the patient, the symptoms, conversation,
Okay, so she found out more in the same space of time by using open-ended questions. Pass the microphone to anybody you don't like. No, I mean, so somebody else who has to contribute next, so but then next to that's very nice. Okay, what else did you see? Okay, so more like a conversation. Not too long. I want to see if you see anything different.
Has to listen to the patient, the second and then asking the first one about just the patient and the second rejected business to the patient.
So there's more, when you said she empathized, how did you see that? What did she do which made you think she was more empathetic?
Just to listen to the patient.
Okay, I listen. Okay, and you notice that she's sympathetic when he's in pain and says, "Can I listen to you? You're okay to continue. Thank you." After that, this goes back to school. Okay.
So now I'm going to go down to the doctors who are obviously much more willing to talk in public. Anybody got any ideas here what the first person was doing, which the second person was doing? There's a particular skill in communication which was working. Apart from listening, apart from being comforting the patient, what did she do that was business? Oh, not so cute. Sorry?
What does that?
The second one was repeating what the patient, information that she got from the patient.
Okay.
So the second one summarised back what she heard, okay, and summarised back what she heard and was very clear in asking the patient. So is that what you noticed? And is there anything else? Now, asking anything else is what's called screening. It's about discovering what the patient understands. Whether the patient has other symptoms, and that's why she found out about the pain, because she didn't explore in a closed way. She kept on keeping it open. What else have you noticed? Any other problems?
Okay, so you're right. There is a difference. It makes a difference to clinical effectiveness. This is not new. Not discovering the reasons for the patient's attendance. Early closed questioning, preventing listening, even in very experienced doctors, they will jump there quicker than you will, there's no difference, but even at the beginning of the consultation, leads to something which spread back in the 1980s called clinical hypercompetence. In other words, people being ineffective in their communication. And these are just research papers over the last 25 years, 35 years, which show that we've known about this for a long time, and that doctors generally interrupt very, very early, assuming the first thing the patient says is the most important, whereas very often second and third thing is equally important. And doctors interrupt at about 18 seconds to such an extent that the patient never finishes their story. So storytelling and listening just for a minute is vital. Let me just show you something in the second half of the consultation, giving information. Here, the job is to explain to a patient about asthma. Now, this is a small clip with a real doctor, Dr. Rob Ross-Russell, extremely well respected in the UK. He's a childhood asthma specialist. He's seeing the parents of a child who was admitted with asthma and has come back to the outpatient clinic. And when he watched this back, he was quite shocked about the way he did this, because he had no idea about his general pattern of behaviour getting into this. And I want you to just look at what is the thing going on here, which is preventing him being effective in giving information. And I'll turn on the doctors this time. I'll be much nastier to you guys. I think you're in front of you. Okay?
In that context, the question is, when should we start the steroid treatment for someone like this, as opposed to every other wheezy child who has come through the door with hot and colds and wounds? And the answer is that there's not better evidence or much better justification, if not evidence, for starting inhaled steroids in someone like him, because we feel that if you've got likely to have pubertal asthma, you are likely to do better if you're on regular inhaled steroids. All right, so we've got this different element. As a group of children, there's no evidence that it's a good thing. So I think particularly given his family history, there is better evidence that it is a good thing to have him on regular inhaled steroids. So my thinking is that if you like, we're in a sort of slightly arbitrary situation. If he did not have a family history of asthma or eczema, I would say to you quite clearly, stop his Pixar, it will make little more difference. Keep his ventilator.
Yeah.
And give him his ventilator when he gets cold, just like you're doing. You can give it 6 hours or 4 hours if you want to. Don't need to religiously give it every 4 hours. You can give it regularly through this whole process. With his story, and I would say that because
I'm sorry I can't show you the rest of this because it's beautiful. It goes on another 4 minutes with him talking, during which time his whole room was wrecked and the computer is switched off by the child. And one of them ends up putting the taps on in the sink, and it's very fun, but it's interesting in the same way. Okay, we then, so let me just find out from the people in the front. Okay. What's he doing there, which is a common pattern in giving information, which is counterproductive in the long run? Can anyone volunteer? It's got these beautiful young and old doctors. This is audience participation, or communication as we call it. What do you see? It's one-way traffic. One-way traffic. So all the communication is going one way. Okay, what else? Okay, so he is talking all the time. What else is wrong with that piece of communication he's doing? We won't like that, but very, very.
Doctor, you get the prior knowledge of the patient and what they want, and without inquiring that, doctors start to give full of information. I think they are not concentrated.
There's lots of information being given, but is it what the patient needs? Did he find out what do you know about asthma already and what do you want to know? Okay, but that didn't happen. Nothing.
The whole family is there, but doctor didn't concern about the family and not qualified the family.
Okay, so the family's running wild here. It's going on, but he continues as if he's just sitting in a room by himself. Yes, not more.
There are a lot of barriers and disturbance going on. No cross-checking also there, getting this information.
Cross-checking.
Regarding this information,
Do they get it? Okay, did they understand it? So not checking that the patient understood. So this is going on all this time, and you could say that the number of children evident is why most of you in the room are not going to become paediatricians, because it's a very difficult, irritating job with these children getting in the way. But despite that, and that's a paediatrician's life, there may be ways to control the children, like you have straight jackets, so you can tie them up, but it's likely to happen nevertheless. Okay, let me tell you what happens in real life. He gives it for 4 minutes. He then says, have I made myself clear? At which point the father says, just how important is the family history of asthma? At which point he repeats the whole 4 minutes again, almost verbatim, word for word. So he's now spent 9 minutes talking to this patient. If you get to the end, you realise that they knew all of this. They were bright, intelligent, had spoken to several doctors before, and they had one very specific question, which related to the length of time they needed to be on the steroid management for and they didn't want to know all the rest. And there was something rather specific about that family history of how important is the family history of allergy, okay? Because the child is adopted. Because he doesn't know. Okay, so finding out what they want to know and asking when he says, how important is the family history of asthma, don't answer it, ask, tell me why you're asking me that question, that sounds important. Okay, so in explanation and planning, he's doing a classic pattern, lots of jargon, I expect you noticed that. A monologue, one-way traffic, speeding up. So when doctors get to the second half of the consultation, giving information, they tend to get faster because they're on safe ground. Whereas actually what you need to do is to get slower, because the patient needs to understand, and not incorporating the patient's understanding or ideas or worries or what they want to know. Shared decision making is something we'll do, can't do today, but it's the other pattern. And of course, the commonest pattern is not giving any information at all. He was really trying to give information, but this was ineffective and took him a long time. I'm going to do one more example, and I'm going to do it slightly differently than I did last time I gave this talk, and it's about cues. And cues emerged throughout the interview, and the key to being an effective patient-centred doctor. I'll just move that one, so I'll probably interfere with it. Okay. So if you go to this style of talking in the first couple of minutes, which is, I'm just going to put my mobile phone down, which might be the thing that's interfering. Which is use open questions and use screening. What else have you noticed? And listening and pausing and minimal prompts and summarising, which we heard about. Then cues and concerns will emerge because you've given them space. You won't just hear about the biomedical perspective, you'll hear about concerns and cues. Now, a cue is a hint, verbally or non-verbally, about some emotional or feelings or thoughts or concerns, and could be about the cause of the illness or could be about what they're worried about. That's a cue. A concern is where it's more directly expressed. So the same thing but actually said. So cues and concerns. Now, are doctors good at picking up cues? No. We know that they're not. In fact, these are major studies, and an example of this is the study in Cambridge, is that back in the 1980s, is that doctors missed 93% of cues. If you look at them, you can see the patient queuing, giving small hints that they're not happy about it, non-verbally. That's probably even more important in your society overall. Western people have got more vociferous. So maybe people are queuing here, or using euphemisms, speaking in ways which are not exactly what you would think directly. And physicians miss most of the cues and actually adopt behaviours that stop them coming out. Why do they do that? Or perhaps it's because they think that if they listen to cues, this consultation is going to go on forever. And I don't think the patient's worried about. It's going to be opening a box of concerns I'm not really interested in. And forever I'll be stuck here taking 30 minutes with every patient. Because as you use one set of skills, you then, if you heard the cues, have to explore them and acknowledge them and paraphrase them and check them. And we could give you a whole other teaching session on skills to get you to see cues and do something. But does it take more time? Every study says the reverse. Yet doctors all feel it's going to take forever. Cue-based consultations in which you decide early on if there is a cue to pick it up, shorten the consultation by 10 to 12%, whether you're in general practice, oncology, or surgery. So we know that it's quicker. So let me just show you the last example here. I'm going to show you this in a slightly different way than we have said, which involves me just doing something which I hadn't thought about doing earlier. So just bear with me for 1 second while I find what I'm looking for. Okay, this is a subtitle consultation. It's between a gynecologist, a very well-established gynecologist in the UK. We video every single one of her consultations with patients in the morning, and we asked her to pick out the one she was most worried about for us to look at together. And this is the one she was most worried about. She said it didn't go well, but she didn't know why. And what I'm just going to show you is the problem with cues being missed. And I'm going to show you just little aliquots of it, tiny bits of it. So this is the patient coming in. She's got endometriosis, and she's coming back for review. And this particular doctor hasn't seen her before. She's seen other members of the team.
Hi, Dr. McDougall. Okay, this is Dr. Brosnan, who's one of my senior house officers. Is that all right if she joins us?
Yeah, sure.
Okay. Now, you took some Zolodex, didn't you, for 6 months, is that right?
Yeah.
And how long have you been on it for?
I can't think my last
About 6 months now, probably, isn't it?
Probably, yeah.
Okay, now there. Can you tell if that patient is happy or not? Do you get a sense of anything by watching her non-verbally, that she's unhappy or uncomfortable, or you don't know what it is? So non-verbally, she's got her arms crossed, her tone of voice is very down, she sounds depressed in her vocal tone. Okay? The doctor hasn't said, at this stage, tell me what's going on or what do you want to know, has launched into, you took this medication, and she says, yeah, that's how long I took it for. But you don't know what she's worried or concerned about, but if you're picking up cues, you think there's something going on here. It may just be she doesn't like coming to see the doctor, but you don't know. So unless you check it at some point, you'll never know. Let's just watch a tiny bit more.
And that was for endometriosis.
Yes.
So how have you been?
Well, I don't think it done any good.
So it's come back, has it?
So that little bit where she says,
I don't think it done any good personally.
So
I don't think it's done any good personally, ... And she says, so it's come back, has it? Whereas a more appropriate answer would be, tell me more about that. What do you mean? We find out why she thinks it hasn't worked, and what has she done about it. Of course, the commonest reason for medication not working is what? Yeah, not taking it. We don't know if she's taking it. Okay. Let me skip.
Try to swim with him. Yes. To suggest really, I don't want to go through that again.
Okay.
I want to suggest really, I don't want to. Yes. Yeah, no. Don't know what to suggest really, I don't want to go through that again. But then I don't want to this pain anymore. Right. So, I don't know. What's your balance like?
So, I don't know, she says, looking upset, miserable. Okay. And the next question is, so what are your bowels like? That is a particular example of blocking behaviour, as it's called. And if you see the cue, you probably hear the cue, and then you go back to something else. Okay? Entirely different. And don't address it. So the cue is, I don't know, and you're correct, you look pretty upset about that. Or maybe, what were you hoping we did today? Or have you got any ideas about where we can go with this? So we don't get to that. And then the last example is, towards the end, you'll see her trying to express now her views, and her not getting to go to the doctor. She's been more overt now.
If that doesn't work, then the other possibilities I can ask them to consider just deferring the one that endometriosis you've got on the landscape. But I'm not convinced really that that's the cause of all of it. Okay, so shall I do that? I'll write to your GP and suggest that on the other settings, I suppose I can write directly to some function.
It seems to me as though since I've had the endometriosis,
Who made the diagnosis of irritable bowel palsy?
it wasn't.
So it seems to me that since I've had the endometriosis, who made the diagnosis? So if you let her continue, find out what she's thinking, what she thinks might be going on. And if you follow it through, she keeps it.
Is that because you're all diet constipation diet?
Yeah.
Both.
He said a possibility.
Right.
And it is because
It's been going on how?
And it is because I got cut off again. Jane McDougall is a gynecologist with a special interest in infertility. At the end of this, she refers this patient to a person who's a physician in intestinal diseases. I interviewed this patient afterwards and asked her how it went. The patient said it was hopeless, really, and I just didn't really get anywhere. What was the problem? Well, I've got this problem with pain, which is difficult, but my GP is helping with that. But the main problem is I can't get pregnant. She's seeing an infertility specialist, is never discussed. Okay, I hope that was instrumental as to why cues are important. Now, research evidence, as I say, very much will say that if you use those sorts of skills, not only be faster, but you'll improve outcomes, as I've said. And if you look at the sort of evidence about this, then you've got evidence that suggests in cancer patients that the amount of information given and emotional support and satisfaction with that is all related to a shared decision-making role together. And that patients who have a structured exploration of their beliefs about their illness actually have a level of personal control and motivation which leads to improved control and medication use over the next 3 months. And that patients with patient-centered communication from their doctor have better recovery from discomfort and concern, and have fewer diagnostic tests. It's better for your healthcare system. Okay, so just briefly a model. How would you put that into practice? How would you teach it in one sense, and how would you do it? And the model I'm talking about is just one of many, but it's the one used in 70% of UK schools. So maybe if you come to the UK at any point, you'll notice students and doctors using it. It's a very simple model that says we can divide this out into areas. There's a sequential flow. There's a structuring component of it, which relates to you organising this consultation in a way the patient understands. And there's relationship building. Without relationship throughout the consultation, without relationship being deliberately built, most of the rest of the consultation is much more difficult to achieve. And you can look at individual objectives within that. It's all on your handout, but using appropriate non-verbal behaviour as the doctor, rapport building, making the organisation overt, establishing all the reasons for the consultation, etc. And if you look at each individual element of it, you can then start thinking, what would you do to make this work? So this is the initiation. Note it doesn't tell you whether to shake hands or not, which will be different in all sorts of different social and cultural settings, but it suggests that you should be thinking about how you're going to develop interest, demonstrate interest and respect, how you're going to welcome the patient, how you're going to introduce yourself and your role and obtain consent, and the key elements at the beginning of a consultation of attentive listening, checking and screening, and negotiating what we're going to do today. And similarly, you can look at gathering information, and as we've looked earlier, there are key sets of skills which enable you to be an effective doctor. Not just asking open questions, it's moving from open to closed at the appropriate moment, summarising, using appropriate language, etc. Okay, so I'm going to finish and hand over to Marcy. So let me tell you the end of my story. So remember those 4 doctors who had been ineffective in finding the diagnosis? What had they done? They'd all done something fairly simple. I'm going to use Marcy as the patient here. Perhaps you just like to perch here. Okay, so she's lying in bed. She has severe chest pain. She's a 65-year-old man, so suspend your disbelief. And the 4 doctors came up to her and said pretty much the same stuff. They were very nice and pleasant. Hello, nice to see you. I gather you've got some severe chest pain. And you've come into hospital. Can I ask you some questions about it, please? So, where exactly is the pain?
Right here.
Okay. Okay. And where does it go? Does it go into your arms at all?
Not sure. Yeah, a little.
Up into your neck?
Maybe a little.
Okay. And does it go? Do you have ankle swelling? Any palpitations?
Not sure.
Shortness of breath?
Maybe a little.
Little bit, okay. Okay. Are you in pain now? Just uncomfortable now, okay. And they all did that. They were safe, cannula in place, enzymes checked, monitored, etc., etc. Okay. So, I watched several people do this, and I'm thinking how I would do it or teach. Fortunately, one of my senior medical students comes up. The fact that I was sitting in the bed next door might have influenced her somewhat, I'm not sure. Hello, I'm John Silver, I'm one of the medical students here. I'm sorry you had to come into hospital today. Perhaps you'd like to tell me all about the problem. And she said something entirely different as the patient, this man. He said, well, I'm not at all surprised I've got chest pain, doctor, because over the last 6 weeks I've had increasing difficulty in swallowing. I can't manage to swallow solid food. I can only swallow liquids now, and I've had time to try and chop up my pills, but I don't think I'm getting them down, so my anti-angina medication isn't working. That's a very different story, which the other doctors never discovered through close questioning. And he had a carcinoma of the esophagus. So that's a very good example about how to do it. Of course, the consultant had it easy. He just came around and said, I'm sure we've sorted out your chest pain. What questions do you have of me? because the job had already been done. Because consultants, as you probably know, don't do anything anymore. So, my message is that this is about clinical efficiency. Now, we're going to now move on to Nancy Rosenbaum talking about, so how would you put that into practice if you were developing a teaching program? In other words, if we're going to teach this, what are the issues and what are the ways of developing such a program? So thank you very much. I'm going to now hand over to Nancy.
And can we just check that if this microphone's off here, I think it won't feedback. So if they're all turned off, we might be okay. Maybe. Yeah, that one's good. All right, I think that might fix it. Maybe. Well, good morning. I'm pleased to be talking to you, following up on what Jonathan has said about patient-centered communication. And now what we really want to look at is, all right, so how do you learn to be patient-centered as a clinician? So these are the premises that Jonathan has already covered. So I'm just going to believe that you're convinced of these three things, that this is evidence-based clinical medicine. Being patient-centered is actually being an effective clinician, and that there's a clear set of skills that he just went through on being patient-centered. And then there's one more premise that I'm not going to spend a lot of time talking about, but there's a huge evidence base for this that says these are skills that can be taught and can be learned. So this leads to a key question, which is, how do you learn how to do this? How do we make sure all clinicians are learning to be patient-centered and effective? And what I'm going to talk about for about 20 minutes is I want to look at this in terms of formal teaching, for example, class sessions, not these as much as maybe small group sessions where people are explicitly trying to teach this. I also want to talk about informal curriculum, which is really a lot of medical school teaching happens much more informally when people are in clinical settings. And then just some practical approaches, both for individual teachers in clinics and in the hospital, but also as far as a broader curriculum. So the thing I want you to all think about for a second, and I guess I'll put it in present tense for all the medical students, but you're all learning how to communicate with patients. So I want you to think about, how did you learn how to do this? So what I want to know with a show of hands, and again, medical students, you're behind all the faculty, so they don't need to know what your answers are. Don't turn around. How many of you, but I want everyone to answer this, how many of you had formal communication training during medical school? Can I see a show of hands? Okay. So students too, did you have formal training during your medical school? And I know you're all seniors, so maybe, maybe not. I see no one in the front rows, which are more of our faculty and practicing clinicians. No one's raising their hand. How about postgraduate training for those of you who are practicing doctors? So I'm seeing maybe 8, 10 people. How many of you practicing clinicians have actually pursued more training in communication through continuing medical education? Okay, so about 10 again. Now I have to say, this is not surprising. I ask these questions all over the world, and the answers, how did you learn about communication formally, depend on one, where you trained and when you trained. So what I have to say is most practicing clinicians around the world, including US and UK, will say they have no formal training in this. You just learned as you went. In the last 15 to 20 years, in some countries and in some schools, there's actually been much more of a curriculum developed, and there is formal training in these, but it depends on where you're from. So we know that in many countries, actually what Jonathan and I are doing is going to many countries where there isn't that much curriculum developed to help people develop more formal training. Part of what we're doing here is to help enhance what you're already doing. Now, part of the reason there hasn't been formal training is some assumptions that are made. And one assumption I think that's made in medicine is, well, we all know how to communicate. Why would you have to teach it explicitly? We just assume you know how, and then you'll just get better the more you see patients. You'll learn how to do it. The problem with this is that clinical communication is different than any other kind of communication. I mean, certainly you're using the skills you use when you talk to your friends and your family, but it's different. And part of the reason why is the focus of what you're doing when you're communicating as a doctor to a patient. And Annie Cushing from London at a plenary talk just a few months ago made this statement, which I think really captures what you're trying to do when you're communicating as a doctor. So what you're trying to do is, one, find out what is the matter with the patient. So that diagnostic reasoning. And two, find out what matters to the patient, which is a lot of what Jonathan was already talking about. It ends up being a unique kind of communication because you're having to do both of those things at once. So even if you're a really effective communicator, you're communicating while in your head you're trying to make sense of what this person is saying, figure out what's going on with them and what you can do to help them. So it's really a different skill set than just, oh, you should know how to communicate. So I'm going to look at formal teaching of clinical communication. So how can we do this in a formal way? And the first thing I want to say is you cannot learn how to communicate from a lecture. So even all the things that Jonathan just talked to you about, a lot of you are probably nodding your head and going, oh, that makes complete sense. Yes, we should not tell a patient everything at once, and we should ask them about their concerns. One of the things I teach about is how to give bad news to patients, how to tell them difficult news. And always in lectures, everyone in the lecture sits there and they nod their head, and they're like, oh yes, that makes complete sense. If the patient starts to cry, I should say something comforting. I should find out where they're coming from. But when it comes time to do it, completely different. The reason you can't learn this from a lecture is because communication is a behavior. It's not just something that you know and repeat on a test. Communication is something that you do. And because it's a behavioral skill, the only way that you can learn it is by doing it, is by practicing. It's being, oh, can I take the knowledge of what effective communication skill is and actually really do it? What we know in terms of changing and enhancing someone's behavior, whether it's communication behavior, prescribing behavior, anything that you do as a doctor, is you can't learn it from a lecture. You have to have an opportunity to be interactive and to practice the skills you're being taught. And it's really easy to think about this when you think about other behaviors. So for example, if you think about learning a medical procedure, you can go to a lecture on a medical procedure. Will you know how to do it just from listening to a lecture? No. You'll have a basic idea of how to do it, but then you need to try it. Often you need to try it, have it not go very well, get some feedback, and try it again. Or thinking about learning to play, can you learn to play the piano from reading a book? Well, you can learn to start to play the piano or from a lecture, but in terms of becoming effective at it, you need to try doing it. So it's useful to think about the way people learn and your choices and how you might learn about this. using this continuum. And what I've been talking about is what's on your left side, which tends to be more facilitator or teacher centered. It's where I'm up here talking to you and you're listening. So you're passive and all the knowledge is being conveyed from me to you, hopefully. Really, to get at what's going to work in communication skills, you have to be on this end of the continuum. You need a chance to experience it in order to change your behavior. So really, it's this difference between cognitive, what's in your head, and behavior. And if you look at different methods that are used, so think about how you learn about this and other things. On the left-hand side, that's knowledge. And the way you learn about those is lectures, e-learning, reading books. The way you learn to do things is by trying them. And in terms of communication, I'm learning how to use this microphone without feedback. In terms of communication, the best ways to learn about it are to practice with actual patients, stimulated patients, role-playing with each other, and then having that reinforced through several things. One is any experiential learning, you do something, actually the way you learn about it is through reflection. So it's not just doing something that helps you learn, it's thinking about what happened and if it worked or didn't. And getting feedback from others on whether it worked, and then getting a chance to try again. So what that does is there's a huge body of evidence, and I have to say one of Jonathan's books actually summarizes all of this evidence that points to what are the best methods to learn to be an effective clinical communicator when you look across curriculum. And they really include these things. So there's that idea of you do need some of that cognitive, conceptual knowledge. What are the skills you're trying to achieve? Then you need to be observed communicating. And one of the best ways to be observed is be videotaped or audio taped, because then you as the person communicating get to actually see it as well as someone watching you. Get feedback on that, and then pretty quickly after you get feedback, get to try it again and implement what people have shared with you. And what we know is the best way is either small group learning or one-to-one, not these big lectures. So I know there's a limit to what you're going to get from what I'm saying right now. So, all right, so what's the good news? The good news is in many countries now, as I said, in many countries, this idea of communication as a core clinical competency is there. In the US, if a medical school does not teach communication, they will no longer be a medical school. They'll get their accreditation taken away. And I think it's similar in the UK and in other countries. So many medical schools now have significant curriculum. Spend many, many hours teaching this to students, helping them learn it in a variety of ways. What we need to say is much less happens during postgraduate. So a lot of people have said they didn't learn it postgraduate, not surprising, and even less once you're a physician. Now, when does this happen? What I need to say is that usually most of the teaching happens pre-clinically. So in the US, we have 4-year programs, usually 2 years pre-clinical before students see patients where they're in lecture halls and small group, and then 2 years of clinical, what do you say you call them, rotations. Now, just to check where I am, this is a 6-year, 5-year school.
Right.
And how many years pre-clinical? Okay. So you spend 2 years pre-clinically here, and then 3 years seeing patients on rotations and working with doctors. So most of the training in most countries happens during those first couple of years. And I know that that's the training that's happening here as well. It started a couple of years ago. Okay, so it's starting, and it's starting in the 3rd year, which is great. Okay, so the good thing about starting to teach it when people first start medical school is it says communication is important. So we're not going to wait till you learn a bunch of other things and then say, oh, by the way, communication would be useful. The other reason I think it happens then is because that's when we feel like we have time to teach it. And it's usually using those experiential things I've talked about. Now, here's the bad news. There's lots of literature, lots of research that shows that in terms of medical students' communication skills, that they actually can deteriorate or get worse over the course of your medical training. So if I'm right, all the students here are in the last year of medical school. What someone would say is that what you see happening with student skills is their skills get better for clinical communication, and then they get worse. And what's interesting is this is when they get worse. So if we're teaching them pre-clinically all these skills, for example, the model that Jonathan presented, students learn that, then they start seeing patients and being with doctors on rotations, and their skills get worse. They decline during that clinical experience. All right, I don't think I have any mics, so. Okay, I fixed it now. All right, so what I want you to do, it was actually a perfect time for the power to go off, because I think it's important for you all to think about what's happening. So what's happening during clinical rotations that might actually make it so the skills that students have learned, either formally or informally, about being effective communicators, that they lose those skills, that they're not as good. And what I want you to do is just turn to your neighbor for a second and say, what do you think is causing communication skills to get worse once students start seeing patients? Talk to each other for a second. Don't look at me, talk to each other. All right, now you've had a chance to talk about it and think about it, rather than run around and put you on. I'm going to talk to you about what we know about this, and let's see if it matches with your idea. What I have to say is there's actually been limited research looking at why this happens, but there's been some, and actually I and some of my colleagues have done some of the research, so I just want to share with you what we found out. So we interviewed senior medical students for 2 years, and we asked them, so how did you learn about communication during your clinical rotation? Not before that, but during your clinical rotation. And they told us 3 things. So you'll see if this seems familiar to you in your own learning. They learned in 3 ways. One was by watching other people. So watching the doctors and watching residents and just picking up from them what is effective communication. The second was just getting to do lots of interviews themselves. The more they talked to patients, they said that's how they learned about communication. And then the third was the feedback they got from their supervisors on patient presentation. Okay, so I'm seeing lots of head nodding and lots of head nodding among the students. So we'd say, yep, that's mainly how we learn. What I want to do is look at what the potential problems with that are. And I'll just share a bit of this with you for each. So the first is this idea that you learn by observing your role models. And for example, at our school, what our learners said, and we did spend time teaching them pre-clinically, actually Jonathan's model, the Calgary-Cambridge model. What they said to us is maybe 30% of their role models actually modeled patient-centered communication. They said 70% of them would do things that did not look the same as what they had learned in their classes and from the models. Now, it's not saying it was all ineffective, but it was not the same as what they were learning. So they would see that, for example, when we talk about being patient-centered, we've already looked at, you need to start by being open, trying to find out what's important to the patient and what all is going on with them. What they would see was actually they report very direct, very closed-ended, kind of like that first example of the two examples that Jonathan showed. Also like the example Jonathan gave from the emergency room of the 4 mid-level doctors. They were doing that. So that's what our learners see. So just relying on goal modeling, then it's up to the students to go, do I want to be more like 70% of the doctors or these 30%? Up to you. So that's one challenge. So then there's just learning by interviewing lots of patients, taking lots of histories. That's the way that you can just learn to be a better and better communicator. The hard part with this is that learning through trial and error. A lot of students said, it was just through practice. I got more comfortable at doing it. I got better at doing it by practicing. The problem with this is experience can be a poor teacher. And one of the biggest problems, and there's lots of really interesting research on this, is how bad people in general, but clinicians specifically, are at self-assessing. How they're not very good at being able to say how good they are at communicating or how good their performance is. And what we know are the people who are in the lowest order, if you look at it objectively, how effective they are, have the hardest time seeing that. So that's this idea of, okay, you're just going to do lots of interviews, and from that, you'll decide what you need to improve and what you don't. And what tends to happen is we have a hard time seeing ourselves. It's just very hard to be aware of what we're doing, what's working, and what's not. The other part of this that we heard from our learners, and seems to be the case in many places, is that, yes, you do interviews, but nobody watches you take histories from patients. People don't watch learners to see what their communication skills are like. And actually in the study we did, our learners said, oh yeah, we get watched all the time. And then we said, well, do you get feedback based on what people see? And they go, oh, no, nobody gives us any feedback. Well, they might go, good job. So then they don't get much feedback on how they're doing, so you don't know what you need to do to improve. The final, and I said people nodding their head for this, is just the feedback you get that students get when they present to their supervisors. So I've just seen a 58-year-old man presenting with chest pain for a duration of that whole presentation. And in our school, and in many schools, people see this is actually the main place clinical teaching happens. Because it's not watching you and giving you feedback. The direct clinical teaching is in response to what learners tell you when they make a case presentation. And the feedback that most learners reported getting was not about their communication skills directly. It was not about interviewing directly. And really, most of the feedback was on content. Well, did you ask about this? What about that? It was not feedback on process in terms of how did you gather that information. Now, the challenge with that is for some learners, they would take that to mean, okay, I have to remember to ask these 15 questions that my supervisor asked about. And it tends to make them go, well, I need to ask these 15 closed questions, as opposed to this idea of, I need to find out this information. I wonder what the best way to do that is. Maybe the best way to get the rest of that information is to ask a mix of open and closed questions. So overall, when you look at this research, what it's saying is that students' clinical experiences often contradict what they might be learning in terms of formal teaching, either pre-clinically or wherever it's happening. And that really the learning happens through what we call informal teaching, or the hidden curriculum. So then the challenge becomes we need to have an impact on that. And we know even in postgraduate, I think it's even more so. No formal teaching and the messages they get through watching, through trying to do things, might reinforce a different model. Okay, so what I want to do is, let me think of how I want to do this. Because I'm just looking at our time. I'm just going to say a few things about what individual teachers can do, and then I'll end with saying just a bit about curriculum. So there are things that can be done informally that actually would help our learners learn more and maintain their skills. So certainly role modeling is still going to be one of the main ways that people are learning, but if you're a role model, and now I'm looking up front here, but the rest of you who are going to graduate and become teachers, think about this too. When you have a learner with you who's watching you, be a little more conscious about what your role model is. So before they watch you with the patient, you can say to them, when we go in to talk to this mother, I want you to notice how I try and find out what she's really worried about. And then make sure that you're modeling those skills. And then afterwards, talk to the learner a little bit more and say, what did you notice? Or say, you know, that didn't go exactly the way I wanted it to. I would have liked to know more about these other symptoms or what's going on. Same with, the other thing I'll push is try to find time to observe your learners if you're a teacher. Even 5 minutes. So we've been watching 3 minutes of videotape, right? The ones we showed you. Look at how much there was in that 3 minutes that you could give feedback to a learner on what's working and what's not. And you use the same steps in observing. Before you observe, say, let's look at this, or is there something you'd like me to watch? Watch it and then debrief. Finally, in terms of learner presentations, think about the cues that learners give you about what happened in the room. It's very similar to patient cues, both verbally and non-verbally. They might say things that can tell you what happened communication-wise in the room. If they don't know what the patient's concerns are, they might not have gotten to that. If they're saying, wow, the patient has so many problems, I didn't know what to do with them, then it gives you some sense that they could use some help with their organization, maybe screening. If they say, the patient's not taking their medication, and it makes me angry, then that gives you a chance to talk about how can you counsel patients about their medication. So there's cues in there. However, one of the big messages of this is you cannot learn to communicate just by relying on these informal means. You need more of a structure, and the exciting thing is part of the reason we're here is because Moody and his colleagues are developing more and more of a structure, and it needs to be part of the formal curriculum. Now here are just some guiding principles about this. One, it needs to be longitudinal, so it can't just be preclinical. It has to go through all years of the curriculum. Now the good part about what's happening here at this school and happening in many other schools is instead of doing it pre-clinically before students see patients, it's being incorporated during everyday learning. So when students start seeing patients, they're also getting formal teaching and communication. It's what we call just-in-time learning, and it's really a best practice because it's not theoretical anymore. It's, I've just talked to these 3 patients, now let's do some formal learning about what skills can I use. And then it needs to continue through the rest of medical school and graduate medical education and continuing. Needs to be experiential, and then something I'm not going to talk about at all, but it needs to be reinforced through assessment. So OSCEs and other assessments. Okay, so here are the points, my take-home points from this, and then we'll turn over to our last speaker. Really, what I want you to take away from this is understanding the best way to learn this is through experiential learning. That it needs to be both through formal and informal, so individual teachers can have an impact on this as well as in the curriculum. And I hope you recognize that this idea of being learner-centered really parallels that idea of being patient-centered. Thank you.
Good morning, everyone. I know I have very limited time, so I will not actually try to cover all the topics I want to cover. Up to now, we have been trying to understand how to make the doctors better communicators with the patients. Okay. Now I will take the other side of the fence and see what happens with the patient. Do they learn about communication at all? Actually, their challenge is much bigger because they have to basically, put forward her or his problem within a very short time in a formal interview situation. So, how do patients cope in this situation? So this is basically what I'm trying to do, basically looking at the patient perspective. Now, I think we heard that doctors and medical students are not well trained for communication. Actually, this is even more for patients because they never go through this kind of workshops. They never get any training about how to, tell their problem to the doctors. So, but it doesn't mean that they don't have any learning process. In fact, they do have their learning process as well. So this is basically what I'm trying to highlight in my short presentation. Patients have their own systems of learning and coping mechanisms. And I think in order to make this communication a two-way communication, we also must try and understand, like, what are these learning processes? I think this was already mentioned in the earlier discussion, so I will go through it very quickly. We have basically three alternative models of doctor-patient relations. One is the paternalistic model, where the doctor is the more active person and he asks all the questions. And as we discovered in some of those videos, he also gives the answers for the most part. So it's not actually a two-way communication. In the second model, we are trying to create a more of a partnership and a participatory process where the patient also can ask questions and actually make sure that the therapeutic interview progresses in such a way that her or his problem gets the focus, sharp attention it requires. So this is where the partnership comes. And we also have a third situation where the patient himself is expert. Not because patient has gone through medical education, but because nowadays, of course, patients can also learn a lot from other patients, from the internet, from medical blogs, and from various other sources. And of course, a patient knows all about his or her problem that sometimes the doctor doesn't understand. So you can also have a situation where patient himself is expert, and I know some doctors may have actually some difficulty in dealing with such patients, especially if they come from the paternalistic model. Clinical situation in Sri Lanka is quite complex. We discovered that even in United Kingdom, sometimes patients come with their families. This is much more the case in Sri Lanka. And often the family is also involved in the communication. Like sometimes instead of the patient, the family member, the husband, like in example given by Jonathan, may also actually try to explain, try to clarify. So it's not just a person-to-person communication. It's a communication process where more than two people are involved, and it's very short. And also there is a social gap between the doctor and the patient. It can be a class gap because they come from different kind of social standings, can be a gender gap, and this is quite important in terms of trying to understand the communication process. What is the role of gender? Sometimes it can be an ethnic gap, particularly in a situation like in Sri Lanka, where you have different ethnic groups. Patients belong to one ethnic group, and the doctor belong to another ethnic group, and their language skills are different. So that also affects the communication process. And this has a lot to do with the trust that is developed and the accountability issues in this communication exercise. The therapeutic encounter, we know, is basically a communication between illness and disease. Illness is basically patient's own idea about, his or her problems, and obviously he or she will have, some explanations, some ideas about the causes, and then the disease is all about doctors' idea of the condition based on his or her knowledge about biological and mental disorders. So there has to be a proper exchange between these two different models. Often there is no proper balanced exchange. As we discovered in the videos we saw, is often the doctor's biological model that is stressed more than the patient's own idea about the problem. And unless we actually adequately understand the patient's own perception, you will never be able to actually convince the patient and build trust with the patient. If you don't fully understand the patient's concern. And patients have a personal experience, so patient knows all about his or her condition, and the doctor has to listen to that story and should not put it in the garbage, as was mentioned in the earlier discussion. And also there is a lay terminology of illness as against medical terminology of disease. Cultural aspects are also quite important in the doctor-patient communication. The way in which patients' ideas in the Sri Lankan context may be sometimes influenced by the Ayurveda ideas about health and disease, in which they are brought up from childhood. So that is part of their learning process. And the language they speak, actually, we have to be far more sensitive to the language in the therapeutic encounter, the words patients use, because they may actually use it in different meanings in different situations. Often they will use indirect communication like euphemism. In their conversation, they may not come to the point very quickly, whereas the doctor, given the pressure of work, want to go to the key point very quickly. So this is one of the problems. And often patients are reluctant to talk about their body and body processes because they're shy to talk about it. So this is another constraint in this communication. I already mentioned about different social factors affecting this communication. Now, you can have a situation where the doctor is a male doctor and a patient is a female doctor. And you can have a situation where the doctor is a female doctor and the patient is a male doctor. You can have a Tamil-speaking doctor speaking to a Sinhala-speaking patient, and vice versa. Each of these situations present a different challenge. Perhaps in the Sri Lankan context, maybe when a male doctor talks to a male patient, perhaps communication is much more smooth. Also, when a female patient talks to a female doctor, it may be the case. But we need to basically understand how gender and ethnicity and other social factors actually interfere with the medical or therapeutic encounter. Now, in the next part of my presentation, basically, I want to briefly highlight how do patients cope with this situation. Like, you know, I mean, they have to basically get across their problem to the doctors, and they have very short time. They may actually respond to this by exaggerating their problem, because they feel that, you know, if they actually state the correct situation, you know, they might not get enough attention. So they might try to, you know, sometimes exaggerate the problem, which actually can lead to some misunderstanding. Often they might try to somatize their problem, try to basically point to you know, what happens to their body, without actually trying to understand, trying to present other features that go with it. Sometimes they may consult other patients, especially this happens in the case of chronic illness, where patients actually meet each other and, you know, they come to the same clinic. So often patients talk with each other, exchange information. So that is how they learn about, you know, how to deal with this problem. They will often consult so-called expert patients, you know, the patients who know about what is happening and who can actually guide the other patients. Often also they might try to get clarification from dispensers, pharmacists, and other caregivers to cope with the situation. Sometimes the more educated patients with IT competency might actually go to patient blogs or go to web and try to get more information about their situation. But sociologically speaking, there are many ways in which patients adapt to these situations, and some of these actually maladaptations rather than you know, good adaptations. Often they may comply less if they don't understand what the doctor said. You know, compliance may be unsatisfactory. There is also what is called doctor shopping. Actually, this is a term invented by a medical anthropologist working in India. He says that there is a very frequent tendency among patients to move from one doctor to other, thinking that the next doctor will be better than the first one. But often they find that it is not the case. So they might even go to a third doctor. So that is not, I mean, getting a second opinion is okay, but if they are moving from one doctor to another just because they could not fully understand what the first doctor said, I think that's not very good. We also have the possibility of for the patients to move from one system to another, because we have a system of plural medicine. They might move from Western medicine to Ayurveda, from Ayurveda to something like Unani or acupuncture. So that possibility is also there. And another important trend is they might actually turn to self-medication without consulting any of them, because they feel that is the only way they can actually deal with their problem. It is totally at their own control disposal, but actually they might do something completely unhelpful in terms of curing the disease. Okay, within the next 5 minutes or so, I will try to basically bring out some specific issues in relation to communication on the part of the patients. Now we know that communication of pain is very important in medical encounters. Here I have listed certain words, singular words that usually come up in relation to pain. I have listed several. Amaru is like a general term that we all use in our day-to-day communication. Vedana is a more general term. Kakuma is a term that is often used in relation to specific body parts and organs like Datkakuma or Badekakuma. Rudava is another term. I don't know whether it comes up at all in the medical encounters, but it is another term that actually comes up in in discussions about pain. It's a fairly unspecific term, and then Ridenava is the verb of that. So what I want to mention is that the doctor should actually be also sensitive to these different terms. Then only they will fully understand what the patient says. Not that doctors should spend a long time learning languages, but I think it is very important part of the training. I know a lot of doctors also try to learn, like Sinhala doctors learning Tamil and Tamil doctors learning Sinhala, but the language of communication is very complex, and we are dealing with very rich languages, whether we are talking about Sinhala or Tamil, and they have very intricate ways of basically describing, presenting various symptoms. And also non-verbal communications are very important. I think in this, in the first picture on the left, you can see a patient with so many questions, but very limited time, and cannot actually ask all the questions from the doctor given the time constraint. So, the person has to actually select and basically decide which questions to ask. So this is where perhaps some better education of patients might be quite useful. And health encounter must be seen as an encounter where there is some empowerment of the patient. Patient will be the final decision maker in this exercise. Actually, the encounter should lead to more informed patient in the end. We have to have a discussion about options open to patients and side effects and after effects, risk management, encourage patients to ask questions. This is something we didn't see many of the video clips we saw. Doctors don't encourage the patients to ask questions. We can understand this because time is limited, but that is not an excuse to actually not giving opportunity for patients to ask questions. We should also realize that better communication and clearing the ambiguities of the patient is much more important in terms of improving patient compliance. Also, I want to say a word or two about health activism. This is, of course, something quite important. The importance of patient networks, patient organizations. In Sri Lanka, I don't think we have too many good, like patient organizations. Probably Cancer Society is one, where there is some effort to actually organize the patients, but in many other conditions, we don't have any, organization to exchange information among patients themselves and try to make them actually good activists in relation to health policy, because they can actually also demand, the kind of health policies that they want from the state and from the government. And also there's patient rights. This is increasingly important in health encounters. So we also have to probably support and strengthen, and as doctors, maybe work with some of these programs for patient activism. Remedies and trends. Here, of course, I will be very quick. I mentioned that patient information sharing is very important, and patient activism can also be quite important. And telemedicine is also becoming quite important in the modern world, because patients learn a lot from TV programs. Sometimes they also get a lot of misinformation about their condition from these programs. Finally, I want to end with some research questions that perhaps should be explored further. One is there better communication in the private sector compared to state sector? And if there is, what are the reasons? So this is something that we don't know. Maybe you have some ideas based on your experience. Also, is there better communication when the conversation is in English as against in Tamil? And if there is, what are the reasons for that? That is also something that we need to explore. And finally, how do patients learn about learn from different sources? I don't think we have a clear idea about it yet. We know that they learn from several sources, but from what sources they get accurate information, from what sources they get wrong information, I don't think we have a clear idea about that. And this is another area perhaps where further research might be necessary. So, with those remarks, I would like to end my presentation.
I'd like to invite Professor Chantika Jayasinha to hand over the certificate of applications to the resource person. Mr. Jonathan Silverman. Proceeding the Silva. With the conclusion of today's proceedings, I think we have just begun an era where the skills of communication is going to be the most important factor in delivering patient care. So I like to thank the resource person, Professor Jonathan Silverman, Professor Marcy Rosenberg, Professor Tudor Silva, and Arosha for sharing their experience with us. And on behalf of Postgraduate School of Medical Sciences, I would like to thank Dr. Rasnaka Mudyanse and Professor Chantika Jayasinha and Dean of the Faculty for all the guidance, courage, and cooperation given to conduct this program very effectively. And I thank the Office of PGSM, the TRC Office, E-Library, and the Dean's Office for all the support given to us. And finally, I thank the medical students, the doctors, and others for participating in this event. Thank you.